circumstances.
Hello, everyone. Welcome so much to this webinar that has been a good collaborative effort between the Kenya Dental Association and the Kenya Medical Association on a topic that has been close to us for the last now 1 year of COVID. And this particular session brings to us COVID and oral health. And we are here to demystify the relation between the two, and also show that we collaborate a lot on many other activities. And with time, the questions that we often have, especially towards dentists, I think will become, we'll get answers for them. Dentists and diabetes later on, transplant patients, are they supposed to see a dentist? The pregnant patients, are they supposed to receive treatment? And this is later on if Kigondu allows. But today we deal with the topic that is at hand of oral health and COVID. And to bring this to us is one of our own, Dr. Dimba, who is an exemplary scholar and has been gracious enough to bring this topic to us. So without much ado, I will ask Dr. Dimba to kindly take it off, and karibu sana daktari.
Thank you so much to our able KDA National Secretary, Dr. Tim Theuri, and thank you so much to Dr. Simon Kigondu for inviting us to collaborate on this important topic of provision of oral health care in the COVID era. So let me just permit me to share my screen so that I can start this discussion. All right, I hope that it is visible. So my topic today for this afternoon is oral health care provision in the COVID-19 pandemic. And I'm going to touch on aspects of policy and practice in Kenya. And the reason why I'm talking about policy and practice is because the pandemic presents us with a very fluid environment where we are forced to set up systems we're forced to set up systems and actually put them into practice with little or no data from other countries. So the outline of my presentation is an update on SARS-CoV-2 and an emphasis on oral health care in a setting where there is a stage 4, stage 5 pandemic. I'm going to dwell on the vaccine update because the Ministry of Health, the CS Mutai Kagwe, has assured us that February is the vaccine month. And there are several considerations that I want to put forward. I'm going to talk about COVID-19 policy. Yes?
Just lift your mic a little just away from you so that it's a bit clear. Pull it away slightly so that, yeah, that's better. Carry on.
Okay, can you hear me now?
Just take it down a little. Take it down a little.
Down.
Yeah, carry on. Yeah.
Is that better? Okay, so I'm going to talk about COVID. You can hear me?
It's disappearing a little.
I don't know what to do.
Okay, yeah, carry on.
I should carry on. Okay, I'm going to talk about COVID-19 policy, protocols, and clinical practice, and then we'll end with a question and answer session. So, starting with the global impact of SARS-CoV-2 on dental practice, I want to just start off by global statistics with more than 500,000 cases per day. Here we have a situation where this is a pandemic that is affecting everybody globally. This is a graph of our national COVID-19 statistics, starting from our patient 0 with the first peak, second peak, and where we are at the end of 2020 and the beginning of 2019. On 1st of Feb 2021, we had around about maybe 85 cases. Yesterday, we had 150 new cases. So we have had two peaks in the pandemic that have taught us valuable lessons, because during these two peaks, I think all of us who are in clinical practice have experienced the same thing. There was such a huge shortage of PPEs. Yes, even if you had good money, you could not get PPEs. Our facilities were either shut down or overwhelmed by the burden of patients, and we had to literally set up protocols on the go. I remember when we were considering the reopening of the University of Nairobi Dental Hospital, where I'm based. We had a series of webinars with our colleagues, our international colleagues, and we sat down and we organized Zoom calls and asked them, ladies and gentlemen, what are you doing on your side? And they asked us, your statistics are better than ours. What are you people doing? So unlike infection prevention, for example, for HIV and AIDS, unlike infection prevention for hepatitis, where you have a bulk of data over the past 10, 20 years, and you can predict the risk levels. Here we have no data and we are literally starting from zero. When we tried to look at the tabulations of the risk levels in the dental clinic, the guidelines divided our patients into two groups: well patients and patients with suspected or confirmed COVID-19. Now, our challenge is this: who is the well patient and who is the patient with suspected or confirmed COVID-19? I remember attending one of these same KMA seminars, where people were sharing their experiences from KUTRH and Kenyatta National Hospital. And they were saying that everybody these days is armed with a laser gun, a non-contact thermometer. And we are busy measuring temperatures and saying that we are screening for COVID-19. However, according to their experience, respiratory symptoms such as coughing were a better indicator of COVID-19 infection than temperature. Temperature can contribute significantly to assist us in screening, but it's not everything. According to our experience at the dental school, for example, a patient will come with a 38-degree temperature because of an active abscess. Yes? So who is the well patient and who is the patient with suspected or confirmed COVID-19? Because if our decision to don PPE is based on whether we are treating, in quotes, the well patient, then we have to come up and be realistic with ourselves and say that actually everybody who walks into that oral healthcare center, who walks into that dental clinic, is a patient with suspected or confirmed COVID-19, and we should use full PPE for them. The next headache is captured in these headings here, procedures that are known to generate aerosols. We're going to look at aerosols in detail, because as dentistry has evolved, we are using more and more aerosol procedures. They cause the patient less pain, they save us time. Unfortunately, the droplets that are generated in those aerosols are the same ones that are going to be used by, to propagate COVID-19 in the dental clinic setting. High-risk personnel and patients, if a member of your staff or yourself is 60 years of age and above, if they have an underlying condition like cardiovascular disease, any respiratory condition, or diabetes, the non-communicable disease spectrum fits here, then they need to comply with the community regulations of avoiding crowded areas and not interacting with people who are sick. In your clinic, those are the members of staff who need options for active clinical service. If it is possible for them to work online, like for example, in the teaching profession, some of our staff are given that option of working online if they are particularly susceptible to the coronavirus. If you have a patient who has a systemic history of cardiovascular disease, a respiratory condition, or diabetes, then you have to exercise extra care with them. The oral healthcare challenge in the COVID era, COVID-19 is highly contagious in the dental clinic setting. I opened this presentation with a photograph of our clinics in the dental school. These are open plan clinics with half a barrier between one dental unit and the next one, so the air spaces are communicating with each other. That presents a particular challenge in infection control. The patients have to remove their masks to receive treatment. So we cannot have a guidelines of saying mask up at all times within the hospital. At the time at which you're doing your cavity preparation, you're extracting the tooth, you're doing the full mouth scaling, the patient's mask is off and you're in very close proximity with the patient. The mode of spread, saliva, nasal fluids, direct contact with the oral mucosa, conjunctiva, or other patient materials. The COVID-19 is airborne. It can remain suspended in the air for extended periods of time, and aerosols, which we are commonly using, will increase the infection rates. If we have contaminated instruments, surfaces, and floors, these provide additional risk in dental clinics. And so what we're trying to say in the COVID era is that we're going to have to unlearn some habits and learn some new ones. With our risk level, and as we head into the second quarter of 2021, we are assured that now we might start having limited access to vaccines. And I'm going to also bring up the issue of vaccines in the discussion on policy, because the processing of these vaccines involved very short stage 3 or safety trials. I'm going to just pick up some of the major vaccines that have received approval. There are almost 200 vaccines in testing stages right now, and they are constantly under review for approval. This is not a list of which vaccine is better and which is not better. I'm going to emphasize again that a lot of these vaccines have received approval with very short stage 3 clinical trials, and I will appeal to the KCOA and the Kenya Medical Association to consider a CME just focusing on vaccines, because there are going to be several cadres of healthcare workers, dentists included, who need to lobby to be prioritized for vaccines. Let's go through this list. You're very much familiar with the Fisa vaccine, and in the brackets, I give a very brief explanation of what the vaccine is about. There are paragraphs and publications on this, and I would not be able to exhaust the information on this, so I've just given very brief notes. The Pfizer vaccine, which is now available internationally, is a 2-dose mRNA vaccine with over 90% efficacy. Now, I'm going to give you an estimate of the efficacy, because if you use this vaccine on one mutation of COVID-19, it might not have the same efficiency on another mutation. So I'm not going to say 92.5%, I'll just say over 90%, okay? So Moderna, 2-dose mRNA with over 90% efficacy. Sinovac, 1-dose attenuated vaccine with over 79% efficacy. Sputnik, the Russian one, 2-dose adenovirus vaccine with over 90% efficacy. Johnson & Johnson, this one is the baby on the block, just recently approved. 1-dose adenovirus vaccine, over 66% efficacy. AstraZeneca, 2-dose adenovirus, over 70% efficacy. Now, these vaccines, which are intended to be 2-dose, Pfizer, Moderna, and Sputnik, have had a few issues in rolling them out, whereby target groups might have access to 1 dose. How much is the efficacy after 1 dose? The estimate for Pfizer and Moderna is maybe 60%. So in these viruses, these mRNA vaccines, which are 2 doses, and the adenovirus Sputnik vaccine, which is also 2 doses, might give a lower rate if the person only has access to one. And with the global shortages, there have been cases where the supplies run out after one jab. Our need for guidelines starts with bullet number 1 on this slide. Most of these vaccines have been approved without extended phase 3 or safety trials. And that means that at the point at which they are being administered to the public, you get now new reports of severe adverse reactions. Yes, the SARS-CoV-2 vaccines are in the global highlight because they are the first use of mRNA vaccines in the general population. What they are trying to do with mRNA is that they're using it as a messenger to bring antigenic information into the cell so that it can produce antibodies. And the antibodies that they want to be produced are the spike protein antibodies, which is that spike that you see outside of the COVID virus. I'll show it to you just now. The mRNA vaccines especially are a challenge because they need negative 70 to negative 80 degrees storage. So there are questions of accessibility. If you don't have minus 80 storage, you're not able to transport this vaccine effectively or to store it well. And then our last bullet here emphasizes that vaccines do not eliminate the need for population-based preventive measures. This graph is a bit of a concern to all of us because the estimates that we are getting from global health bodies is that by late 2021, these green countries will be able to achieve widespread vaccination, adequate to give that immunity to their populations. The ones which are light green by mid-2022, and that is these countries here. By late 2022, here is our beloved country, Kenya. We might be able to achieve something. The bulk of Africa, early 2023 onwards. Now, there are questions of equitable access because if you look at these countries which are colored bright green, what they have done is that they have stockpiled, which is a commercial arrangement between them and, for example, Pfizer, between them and, for example, Mrna. They have stockpiled enough vaccine to vaccinate their populations times 3 to times 5. That is why they are saying by late 2021, they're going to achieve their goals. The question that I'm sure the epidemiologists are going to start asking very soon is that is very good for them. It is very good for them. But is it a viable strategy for the pandemic? Because if these countries vaccinate themselves and the COVID pandemic continues raging on in other parts of the world, and we have new mutations coming up, what if we get a nice new mutation that is completely resistant to this vaccine and we go back to square one? So a strategy that might be very strategic for a small group of people might not be a good strategy for the pandemic. So let's look at, in terms of policy, like I said, we sat down at the School of Dental Sciences and we, did the Zoom calls and we contacted our international associates and we asked them, what are you doing? And they said, you know what? We have no idea. What are you doing? So in response to the pandemic, we had our professional associations coming in and intervening very fast. I'm not going to go into the full details of these links, but I just want to highlight the policies they're in. The Kenya Medical Association came up with the COVID management protocol, which gave a case definition for screening. Who is clinically suspected to be COVID positive? We're going to go into those details, the practicality of it, and who is not. Who is supposed to go for the test because we have a limited number of tests and who is not. Testing procedures were outlined in this document. Isolation and quarantine protocols were outlined in this document. I'm going to dwell a little bit on this bullet because according to our practical experience, we started towards the last quarter of 2020, seeing dental patients, first of all, for emergencies only, and then after that, routine cases. And we had an incident in our center where one student in one of the rotation groups tested positive for COVID. And so we had to look and practically implement some of these isolation and quarantine protocols. For you to be eligible for home-based isolation, you need a separate room, which is ensuite. And by ensuite, we mean that you need to have a toilet and a bathroom to yourself, yes, so that you're not sharing facilities with the rest of your family. If you do not have a separate ensuite room, then you are not qualified for home-based isolation. You need to report to a quarantine facility to isolate properly, yes? And when one of your staff or one of your students tests positive for COVID-19 and is under home-based isolation, they are only cleared to start rotating in the hospital again when they have two negative tests following each other. So these are the isolation and quarantine protocols. What we did in the School of Dental Sciences is that once a student tested positive, for example, on a Saturday, we tracked the students' rotations, however perfectly or imperfectly as we could, to the best of our ability, for the past 5 days. Any nurse, any colleague, any lecturer who was in direct contact or rotated with that student had to go into isolation. And that's the practicality of it. Yes. So management of patients with the COVID-19, I think, was left to the medical fraternity, and they have, I think, quite successfully disseminated their protocols in terms of CMEs, and then patient discharge protocols most relevant to our practice as oral healthcare workers. Those two negative tests. Nobody reports back to work without the two negative tests. Internationally, the FDI gave some general guidelines. I've also provided the link, and I'll give this PowerPoint to Dr. Theuri for anybody who wants access to it. The FDI outlined the need for physical protection in terms of PPE, the surgical masks, gloves, protective wear as appropriate for the care being provided, and then appropriate vaccinations against infectious disease according to the current guidelines and practice guidelines at national level. So our practice guidelines are derived from the Kenya Dental Association. And I'm going to repeat the appeal to the KMA and the KDA to issue to us guidelines. For example, now, if I have all the literature on vaccines that I have seen in 3 previous screens back, which vaccine is safe for me? That is the question that I would really beg to have answered from our professional associations. We continue with oral health policy, and KDA gave us practice guidelines, starting with telephone triage based on the COVID-19 case definition, where your patient calls in and you walk them through the checklist before they come to your clinic. A physical triage center has to be set up before treatment, where the patient is again walked through the COVID checklist, their temperature, and the temperatures are taken before being seated on the dental chair. The Kenya Dental Association also lobbied for access to PPE for oral health workers and instructed us to use pre-procedure mouth rinses with oxidative agents such as hydrogen peroxide. We started off in around about maybe April or May 2020 after these guidelines with emergency treatment only. The use of rubber dam isolation was emphasized in the guideline, and they also urged compliance with the Ministry of Health distancing guidelines as the patients move through our health facilities. Disinfection of clinical premises was reinforced, and training. They gave a training recommendation in the School of Dental Sciences. The COVID practice guidelines have been provided by a team that I'm coordinating to almost 300 persons. Yes, so all staff went through that training. We divided the groups into teaching staff, which is the doctors, and then the non-teaching staff, all cadres, the nurses, the lab technicians, the cleaners, the cafeteria workers, the groundsmen, and the watchmen at the gate, because the watchmen also do take temperatures with a non-contact thermometer, and they guide people into the dental hospital through the hand wash stations. They guide people to the triage tent. So we had to train everybody in the dental hospital, because, well, if one of the groundsmen is COVID positive and he walks through the clinic and infects everybody, we will all go into isolation. So this is something that we are encouraging all facilities to do, to organize for formal training for all your cadres in the dental clinic. In terms of protocols and guidelines, what I have put up now is what is available online. Each dental specialty needs to review its infection control protocols. We need to unlearn some stuff, and then we need to learn some new stuff. Yes, for example, my specialty is oral pathology. I do not frequently need to use a rubber dam. Yes, but the endodontist is going to use a rubber dam on a daily basis, and they are the ones to contribute towards guidelines of the same. Yes, in this process, the professional organizations are key stakeholders in the discussion, and the guidelines for clinical practice are constantly evolving globally. A lot of professional organizations are talking in terms of interim guidelines. This is what we are doing for now as we get more data, yes, and as we gain experience in the management of patients with and without COVID-19. There is, I am saying it again, an urgent need for a national vaccine guidelines, also because there's a lot of vaccine resistance out there. Nobody has ever heard of an mRNA vaccine. People are hesitant about it. The more information we get, the more compliance we're going to get towards vaccinations. I've gone through these OSHA guidelines, and this is a table that we have used for training different cadres at the dental hospital for rational usage of PPE. We call it rational usage of PPE because the PPE is only effective if it is the right item and used rightly, and it's not to be used lightly or misused, because if we waste PPE, then somebody else who needs it urgently is going to miss it. And for the clinical cadres, we said that for dental clinics, we started off with emergency only. Now we are doing routine cases as well. Definitely, we have been using gloves. Surgical masks have been used as a matter of routine. We added the N95 mask to our PPE that is used for routine cases. We need disposable gowns, eye shields, caps, and shoe covers. Now, for these disposable gowns, because of the numbers that we are dealing with in the dental hospital, we also developed a system where we have the reusable gowns put on top of scrubs, yes, and then laundered on a daily basis, such that the outer gown that the student or staff member is using is left in the hospital assumed to be contaminated. And that so far has worked a bit well, because the cost of disposable gowns for 200 plus students is a bit prohibitive. Action points inside the clinic: we have placed bottles of alcohol-based 70% hand sanitizers. We wipe down all surfaces with hypochlorite or 70% alcohol after each patient. And then we have, the high-touch surfaces like light switches, door handles, stair banisters, and so on, which need to be cleaned on a regular basis. We are encouraging the patient chairs to be positioned more than 1 meter away from the doctor, and always close to a window so that we have good airflow. We are discouraging handshaking. Now we have like the fist bump. The students are doing that. Shake with your elbows, shake with your foot. We are very good greeters in Africa, so we have to unlearn some of the stuff that we normally do, and we learn some new stuff. I'm going to go into the discussion on preparedness now. Preparedness for the COVID-19 pandemic starts with your staff members. It starts with your oral healthcare team. There's a self-assessment tool that was printed out by the Ministry of Health, and it has an easy-to-use checklist. Fever above 37.8, cough, any trouble breathing, any chills, any muscle ache, sore throat, loss of smell, loss of taste, nausea, vomiting, diarrhea, headache. Anybody who ticks more than 5 of these in the morning does not leave home to come to work. Yes? Anybody who ticks more than 5 of these in the triage tent is set aside and facilitated to have a COVID test. Yes? And then after that, now we start talking about self-isolation and quarantine. So if you're not using this already in your clinic, we would encourage you to use this dentists and our respected colleagues from other healthcare cadres for self-checking before leaving home, and then triage as your patients come in. And then part of the preparedness is posters inside your clinic. I've given some examples of the posters that we are using at the dental school, where we are encouraging maintaining a physical distance when they are queuing, when they are sitting. If you tell them 2 meters, you know we are very social people. If you tell them 2 meters, hopefully they will, when they cluster together, it will narrow down to 1.5. We have various levels of perfection in implementation, but as I said when I was starting this lecture, we have to unlearn some things and then learn some new things. This is another example of a poster that we are using, where we are encouraging mask wearing in the hospital, and then hand washing, because we have set up a hand wash station outside the hospital as the people walk in. So now if you're providing oral health care, the only time that the patient removes their mask is when you're actually working on the patient. Like I mentioned, one of the first steps in our hospital was to set up an infection prevention and control team, of which I am the chair. And here we are trying to adopt a scientific approach and give practical solutions designed to prevent harm caused by infectious disease to patients and healthcare workers. And our top priority in this is COVID-19. So the standard precautions are guidelines for the prevention of transmission of disease, and they're going to combine universal precautions and body substance precautions for all patients, regardless of diagnosis. One of the major challenges that we were facing is the challenge of bioaerosols. Yes. So as I mentioned very superficially in the introduction, the high aerosol procedures in dentistry have been widely adopted. We're going to go into the images just now. They're faster and less painful. The hazard here is that if we have microbes plus water plus saliva, we have a bioaerosol, and we are going to see this in our high-speed hydro-cooled handpieces used in conservation, and that is the filling of teeth, and also in surgery. We are also going to get bioaerosols in the ultrasonic water scalers used in perio. Now, one of the solutions for bioaerosols is the use of vac stations, and we have one of our colleagues in the conservation department who can give access to this. So there's a filtration, a suction system which gives through a HEPA filtration will neutralize your bioaerosols by passing them through filters and UV light, neutralizing the microbes within. We're also in addition to the vac station, encouraging the use of 400 dentistry so that we can increase our efficiency in the dental clinic. Cleaning and more cleaning is recommended. Transmission risk of COVID-19 is due to the spread of infectious droplets and long-term survival in the environment. So if we look at some of the materials that we commonly use in to set up our clinics, like metal, glass, ceramics, a lot of us still use paper files, plastics. COVID containing droplets can survive there from anything between 2 to 3 days up to 5 days. So the reason why we were training everybody, including our cleaning teams, is because you have to emphasize and re-emphasize to your team after every patient, you're going to have some thorough cleaning and aerating of the workspace before a new case comes in. Our common disinfectants are easily available. 0.1% or 1,000 parts per million hypochlorite or jig solution, 70 to 90% alcohol used to wipe the surface, and they are supposed to be left in contact with the contaminated surface 5-10 minutes and then wiped off. Your cleaning staff have to use correct PPEs. We had to take our cleaning staff through this training because sometimes they would clean the units after a patient, maybe without gloves, maybe without a mask. And I think to remember about our 70 to 90% alcohol, hands need to be kept away from flames after sanitizing. And this is something that we had to look at, especially in the prosthetic department, where they, in the prosthetic lab, they work with a naked flame. Yes, somebody is sanitizing their hands and you have a film of alcohol on the hands and then expose it to a naked flame. We have this new phenomenon of hand sanitizer burns. So for the prosthetic clinic, they are better off using 1,000 parts per million of jig as a cleaning fluid. For cleaning between the patients, we are advocating for 15 minutes between patients. It is going to slow us down. Definitely, it is going to slow us down. But in the interest of safety, this is something that we have to do. We have to learn to do this and then unlearn the quick cleaning that we used to do. The person who is responsible for undertaking the cleaning with detergents and disinfectants should be trained in the process. And I'm urging our colleagues who have their private dental clinics to take some time and walk all their staff, from the receptionist, everybody, through COVID training. Healthcare waste and any other disposable items should be removed and treated as contaminated. If you have an inpatient facility, the bedding and the bed screens should be treated as infectious linen. The linen should not be shaken out. It should just be rolled up and put aside for washing. There should not be a communal cleaning trolley or a cleaning basket that moves from the dental clinic to the reception, to the toilet, and so on. The cleaning of your facility should be compartmentalized. Use laundry. Dispose it in clearly marked containers. You make sure that gloves are used when handling used laundry. Don't shake it out, and that will minimize the possibility of further dispersing the virus in the air. Items are laundered at 85 degrees in a washing machine. Before the COVID pandemic, we never used to do this in the dental school. And then a group of young enterprising doctors, I think Dr. Karia led that team, did a fundraising and secured for us a washing machine where we do in-house washing of our protective wear. There are large volumes of waste that can be generated by frequent use of PPE. So we do have a medical waste disposal problem because of these new protocols. Talk to your clinical waste management company and then see how you're going to coordinate it. And all waste in the COVID era is disposed of as infectious waste. Our final consideration before I go into the details of the preparedness study, our final consideration is that stigma should be avoided, because when COVID patients are stigmatized after the 2 negative tests, It reduces people seeking medical care. It reduces people seeking for testing. And so when this group X of students who are isolated because one of them had tested positive for COVID, sure, all of us have a healthy respect for death, but we just welcome them so long as they have tested negative and we integrate them back into our system. So I'm going to take just a very few minutes to describe the COVID-19 preparedness study, which is being conducted by myself, our Dean, Regina Mutave, Professor Kemoli, and a young intern by the name of Dennis Kimathi. The problem statement is that, okay, at the current moment, the restriction of elective procedures and rational use of PPE have slowed a potential surge in the COVID-19 pandemic in Kenya. We looked at our statistics at the beginning of the lecture, and it is unfortunate. It is unfortunate that almost 2,000 people have died due to COVID, but we have slowed down the pandemic to a certain extent. Yes. Operation of oral health facilities at minimal functionality is not a sustainable option for long-term planning. COVID is here with us to stay. Yes. So our justification is that oral healthcare workers are well placed to play a positive role in disease surveillance. We can catch, we can separate the patients who are manifesting signs and symptoms of COVID and direct them towards testing facilities. The close proximity of our work to the nose and the oral structures of patients also make us uniquely susceptible to infection. You can imagine a situation where you want to make that beautiful cavity preparation. Previously, we were almost entering into the mouth of the patient. Now we have to think otherwise. So we needed to conduct a situation analysis of our preparedness for infection control so that we can give evidence-based recommendations for safe practice in oral health care clinics. There is no data. We asked our colleagues in the UK, in the US, in India, what are you doing? They said we are doing ABCD. Based on what? There is no data. So we have to generate data and then provide an evidence base because everybody is starting from the same level. And this it demonstrates our situation in the dental clinic. We are advocating for 2 meters social distancing so that we can avoid this. And then we go to the dental clinic, and here we have our dear colleague doing a cavity preparation. This patient, we are not sure whether they are COVID positive or COVID negative, and the aerosol from the high-speed handpiece is going like that. Inside the droplets of the aerosol is our SARS-CoV-2 with the characteristic spike proteins sitting there. So our occupational health is at risk. The general objective of the study is to assess the level of preparedness among oral health workers in Kenya for infection prevention and control during the COVID-19 pandemic. Specific objectives: to assess the knowledge amongst oral healthcare workers for infection prevention and control, to evaluate the attitude amongst oral healthcare workers for infection prevention and control, to determine the infection control practices of oral healthcare workers in Kenya. We have different levels of infection control practices. There are people who, even before the COVID-19 pandemic, had state-of-the-art sterilization in their clinics. There are other groups where running water is a problem. So where are we in terms of infection control? And that is what we want to determine. Then, having that data, we are able to advise the policymakers that oral healthcare workers need ABCD, but without the data, we're just, we're trying to respond to a situation where where we are partially blind in a way. Yes, we are partially blind. So the fourth specific objective of the study was to describe the access of oral healthcare workers to personal protective equipment for infection control and prevention. Some of our dentists, some of our medics are going to have access to a fresh N95 mask every day. Some of our oral healthcare workers, some of our medics are going to pull me to the side after a training session and ask whether they can wash the N95. Yes? Study population. The study population includes random samples of oral healthcare workers using the current registration of licensed dentists and cohorts as a sampling frame. We are going to include the ones who are currently in clinical practice and those who are willing to participate and who give consent. Those who don't give consent will exclude. Those unwilling to participate, we will exclude. So a structured self-administered questionnaire will be distributed in person by Dr. Kimathi Dennis. If you see him knocking on your door, please don't chase him away. He's very enthusiastic and he wants to help. Where possible, we're also going to use SurveyMonkey data. The data is going to be analyzed with Microsoft Excel and SPSS and processed in different forms for publication. And only the principal investigator and co-investigator will have access to the project data. We had a bit of resistance because we have collected data from 120 people so far. We are not spying on people's clinics. Yes, this is our ethical approval. We're not spying on people's clinics, and we're not out to finish anybody. We just want to answer this question: how are we coping, and can we cope better? Changes in clinical practice and COVID interventions from the end of 2020 include access to vaccines, hopefully from the second quarter 2021, and access to vac stations from the third quarter 2020. I must say both number 1 and number 2 are currently in pilot stages, very rare. Okay, and so I was asked to talk for 45 to 50 minutes. So I'm going to stop there in the interest of time. And this photo that I'm stopping with gives us the good old days where, you know, your high-speed handpiece is there, your aerosol is floating around, and you have no worries. Now we have to worry about that. Thank you.
Right. Thank you so much, Dr. Dimba, for that enlightening talk. That has been really, has had a lot of information, especially from the field of dentistry, from which we come from. At this particular point, I'd like to encourage us to answer questions, ask questions. The only one that has been here possibly that will be answered by Kigondu regarding the CPDs. But over and above that, I'd like to thank you for the talk you've given us. Those who joined in a little late, Dr. Dimba is an oral pathologist and a senior lecturer at the University of Nairobi School of Dental Sciences with a lot of experience in research and academia and a strong publication portfolio. She does a lot of consultancy for medical organizations such as the World Health Organization, and is currently the chairperson of the School of Dental Sciences Infection Prevention and Control Committee. And as you have seen, she's also a principal investigator in the study she's just given to us. So asante sana, Dr. Dimba. And I am not seeing any further questions or comments regarding the session we just had. So I will ask Dr. Kigondu, should there be anything he needs to add onto this?
Yeah, thank you very much, team. And I think that was a very exhaustive talk, and that just goes to show, demonstrate the danger that COVID has, especially for people who work around the mouth, the salons, and anyone operating around there. And I think we also want to appreciate that the professional associations have had input to helping professionals battle the pandemic. And this is one of the ways, providing weekly CNC on the we want to thank the dental team for that particular talk. I am sure they will have another one next week, and this COVID case management series are a partnership between KMA, KDA, KMPDU, NNAK, National Association of Kenya, and other associations, Kenya Clinical Officers Association, and the others. So we want to appreciate you, and we will have the NNAK representative make a closing statement and tell us about the call.
Thank you so much, Dr. Kigondu. That was actually a good and informative topic. that all healthcare professionals should learn something about it, and especially the nurses who are in the clinical setup, to learn and also to share with the others. On the other hand, we have a call center. During this time, we have so many mental disturbances, and we urge all the healthcare workers and their families to utilize this service that we have for them. They're able to call in through the 3 numbers, that is 011 00 988 70 and also 011 00 988 71. They can be able to call us and then we'll be able to reach out to them. This is the healthcare workers' psychological support. We have trained medical and clinical psychologists to be able to handle the concerns that will be raised. Thank you so much. Back to you, Dr. Kigondu.
All right, as Dr. Kigondu is coming back up, we have a quick question for you, Dr. Dimba. And it's from Dr. Okumu Brenda, who is asking, have you come up with specific guidelines for conducting dental outreaches at School of Dental Sciences? You could kindly unmute your mic.
At the moment, we are not conducting any outreaches due to the different levels of the pandemic in our target areas. But that, I think, what Dr. has asked is something that is very relevant, and we need to sit down, I think, in consultation with the public health experts and process these guidelines, because, as I said, the COVID pandemic is here with us to stay. It had a beginning like the HIV pandemic, and we have to develop ways of working around it. The need for those guidelines is well received.
Right, thank you for that, for answering that. I do not see any other. Dr. Faith Kilonzo thanks you for a brilliant presentation, and she has well understood what we have talked about. Now, next week, we shall bring another session, another similar session to this from the dental surgeon side. And this will be more of a case management from the maxillofacial surgeons who have also been at the front in dealing with the with trauma in this era of COVID. So without much ado, I'd like to thank you, KMA and Dr. Kigondu and the rest of your team for this collaborative effort that this being the first, I hope to see many more of these sessions, to not only include COVID-related matters, but also to expand the discussion so that we are able to demystify the relations that we often have as medics in the field. So asante sana. If we have more time, that should be it from us. Thank you, Dr. Kigondu. Dr. Kigondu, final remarks?
Oh, thank you. We want to ask Dr. Mbao Kitau of the Pharmaceutical Society of Kenya to close for us. The Pharmaceutical Society of Kenya is also one of our partners in this COVID. Dr. Kitau.
Asante, Dr. Simon Kigondu. Mine is not much but to thank Kenya Dental Association, Dr. Tim Deuri. Asante for the great work that you have done today. Dr. Dimba, asante Nisana. And just to overemphasize on the need for us to continue using the call center, ladies and gentlemen, it's a high time that we work on ourselves. The call center has been developed for the healthcare workers, and it's just been developed for us, and it's by us. It's the high time we utilize it, because at this moment we're finding that guys are getting burnouts, just feeling at times lonely, even for your family members. Remember that the call center is open to either you or your family members. So I'll just request you and to probably overemphasize on the need for us to utilize the call center. So Dr. Kigondu, from the Pharmaceutical Society of Kenya, we are grateful for what Dr. Tim Dewi and Dr. Dimba have done. And probably from my end, we have noted that Dr. Dimba has said that there's emphasis for us to have a COVID training on the various vaccines that are in use. And thank you, Dr. Dimba, on touching on that, on the various vaccines that are in use. So Dr. Kigondu, on your side for the training part, kindly ensure that we have a detailed webinar for our members probably on the vaccines, the various types of vaccines in a much in-depth way. So from the Pharmaceutical Society of Kenya, nothing much but to say thank you very much for the presentation today.
Thank you very much. And with that, I think we can end the session. And note, and we'll see you next week. Same place, same time.
Thank you.
All right. Thank you so much. Thank you, everyone, for attending. Keep safe. See you next week at such a time.